advanced premorbid conditions. We have two units, and one unit is specialized in neuro and cardiac premorbids. That's where I'm working. And then we have another unit that specializes in respiratory problems and hematological conditions in pregnant patients. So for the last 10 months, I've done my core competences and intermediate competences. Started my higher competences in cardiac ops as well as neuro ops. Okay, so today we will discuss about valvular heart disorders, and our learning objectives for this presentation are to appreciate the role of valvular disease as a cause of maternal mortality, and then describe normal cardiovascular physiological changes, and we will discuss about the etiology, pathophysiology, investigation, and management of different valvular heart disease in pregnancy, and how these disorders affect anesthesia in pregnancy. So before we actually start with the cardiovascular changes, I'm just going to tell you briefly about the scope of the problem. So there's a trial named as Embrace UK. It was done in 2019, and if you see the results, you can see it yourself that heart diseases is by far the most predominant condition that leads to the maternal deaths. 23% of the people of the women died in UK last year because of the cause in the maternal death was 23% was due to the heart disease. And then there was if you look at if you look at the trends, what are the trends? So there was a trial that happened in CEMACH Trial. It was done by Nelson Percy, and if we just probe what type of heart disease, which one is getting more prevalent, so you can easily see that it is the acquired cardiac disorders that are increasing day by day. So so the red line indicates the acquired cardiac disorder, and as you can see, they are just peaking up just because of the rising risk factors of hypertension, enhanced obesity, diabetes mellitus. All those things have skyrocketing the acquired cardiac disorders. And you can see the congenital heart disorders, they are declining. They have declined to 2006, in 2006 they were declined to less than 5%. And if we again see Embrace UK and the 2019 data, you can easily see that, valvular heart disease comprises 7% of the maternal deaths, but the congenital cardiac disease only 3%. So, but I looked at the data from Pakistan. It's a bit different in Pakistan. Congenital cardiac disease in Pakistan still comprises roughly 20%, but valvular heart disease comprises more than that, even in Pakistan, just because there is a more increased incidence of rheumatic heart disease in Pakistan. Anyways, so we will quickly go to the cardiac physiological changes. So one has to have a very good idea about what are the normal physiological changes and what are the abnormal physiological changes during the pregnancy. So briefly, heart size is increased, cardiac output increases, heart rate increases, and stroke volume increases. And in terms of blood pressure, so the blood pressure has a variable effect. We will talk about it. So if we look at the cardiac output, it increases by 50%, and and half of it is because of the increase in the stroke volume, and half of it, 25%, is due to the increase in the heart rate. Left ventricle and diastolic volume increases just because there is an increase in the venous turn and decrease in the SVR. Ejection fraction on the whole increased by 5%, while pulmonary capillary wedge pressures, CVP, left ventricle stroke volume, all of those things remain unchanged. SVR decreases by 20%. Now, the most important change that occurs is the increase in the cardiac output. And why there's increase in the cardiac output? It's just because there's an increase in the progesterone levels during the pregnancy. And progesterone has an effect on the collagen vasculature. There's peripheral vasodilation, and just because there's a peripheral vasodilation and there's decrease in the SVR, the afterload decreases, and the heart and the cardiac outputs gets increased. The cardiac output increases by 5%, starts increasing by at the end of the 5th week, and it keeps increasing, and it reaches 20% at 8 weeks of gestation, and by 20 weeks of gestation, it has increased to 50%. And you can see this is achieved primarily by an increase in the stroke volume as well as an increase in the heart rate. Okay, and if we look at if we look at labor, this chart over here. So when the patient goes into the labor, there are two stages of the first stage of the labor, the early and then late. So in early stage, the cardiac output increases further of about 10% of the pre-labor levels, and then in the active first stage of the labor, it increases further by about 20%, and then in the second stage of labor, it increases more. I mean, about 40% of the pre-labor stage, and then immediately after labor, in the third stage, early third stage, cardiac output has increased to 150% from pre-pregnant level. That's a massive increase in the cardiac output, and this is what drives these women with valvular heart diseases. They they make them off balance, so that's the problem with them. Anyway, and all those changes return back to the normal by the end of 2 weeks. It takes about, 2 to 3 weeks for all those changes to come back to normal. Heart rate decreases rapidly afterwards, and stroke volume takes a bit of time to come back, just because heart is physiologically enlarged. So now, when there are physiological changes going on, so the examination findings are also gets changed. If we examine the heart, if we auscultate the heart, you can find in the S1 first half sound is accentuated, it gets loud, and it gets splitted. So it's a physiological splitting of the S1 component. That's normal. And then you can also find a systolic ejection murmur, and it's a grade 2 systolic murmur that you can find that's normal, and you can find it on the left sternal border in the fourth intercostal space. Okay, and then you can also find in 15% of the women, you can find S3 and S4. They don't have any clinical significance. It's quite normal. And then just because there is a cephalid displacement because of a gravid uterus, so the heart shifts and the apex beat tends to be more towards the left, and instead of lying in the fifth intercostal space, you can find it in the fourth intercostal space. So that's the normal physiological changes. Okay, so but remember, there will be, yes, there is an increase in the cardiac output, but you will not find an increase in GVP. So if you find raised GVP, that's not normal. Okay. Similarly, edema, you can find peripheral edema in the third trimester of pregnancy. That's normal, but it should be symmetric. If it is an asymmetric edema, then that's not normal. Okay. If you look at the echocardiography findings, they demonstrate a left ventricle hypertrophy by 12 weeks of gestation, and there is a 23% increase in LV mass from the first to the third trimester, and overall there's a 50% increase in mass at term. So 50% increase, that's quite a lot, isn't it? And this hypertrophy is an eccentric hypertrophy. It results mostly from the increase in the size of the pre-existing cardiac myocytes, and it resembles the changes that occur from repeated strenuous exercise, just like you find in athletes, okay? And the annual diameters of the mitral, tricuspid, and pulmonary wall increases. 94% of the term pregnant women exhibit tricuspid and pulmonary regurgitation, so that's normal. So in 94% of the pregnant women, they can exhibit TR as well as PR, but that's normal. That's completely normal. And 7% exhibit mitral regurgitation. That's normal again. That's normal. The aortic annulus does not dilate from normal pregnancy. Even if there's increase in cardiac output, and it's like 50% to 150%, increase in cardiac output that occurs, but the aortic annulus does not dilate. Coming on to the ECG changes. So ECG changes become relevant in the third trimester of pregnancy. Heart rate increases steadily during the first and second trimester, and the PR interval, as well as the uncorrected QT interval decreases, not the corrected QT interval. And this finding is important in the women that have a long QT syndrome. And the QRS axis shifts to the right because, I mean, the apex, of course, I've told you that it gets shifts. So the QRS axis also gets shifts. You can also find depressed ST segments and isolactic low T-wave changes in the left-sided precordial and limb leads. So that's normal. So if you find a T-wave inversion and a depressed ST segment in V1 to V2, that's completely normal in third trimester of pregnancy, nothing to be worried about. So when we talk about in the labor and postpartum, we discussed about the cardiac output and the venous return. The only thing that I'm going to discuss about over here is autotransfusion. So one has to know, and this is an important phenomenon. This is quite an important phenomenon. When the baby is delivered in the third stage of pregnancy, and in the third stage of labor, after that delivery of the placenta, and when the uterus contracts, so there is an interval space in the uterus, and it holds like 300 to 500 mils of blood. So when the uterus contracts, this 300 to 500 mils of blood goes back into the body. It gushes back into the body. And it's like somebody has given you a 500 mils bolus in just a minute. So that's quite huge. And if a patient that's that has an unstable cardiac condition, if that thing happens without any assistance, and if that thing happens at once abruptly, that can lead to so many complications. The other thing that I'm going to discuss about is aortic cable compression. So aortic cable compression becomes significant in the late second trimester and then onwards to the third trimester. And if there's significant aortic cable compression going on, you can find different blood pressure on the upper limb as compared to the lower limb. The important thing is the blood supply to the fetus and placenta, it arises below the compression. So if there's a aortic cable compression going on and it's significant, it can lead to fetal distress. Okay, and there will be a decrease in uteroplacental flow, and the fetal placenta circulation will be compromised. So the best position to relieve aortic compression is left decubitus, but in the lateral position. But no procedure can happen in the lateral procedure. In the lateral position, there can be no obstetric deliveries that can be done into the lateral. The surgeries can't be done. So the researchers have found out if you give a 15-degree tilt, then it releases this compression by 70%, and I think that will be more than enough for most of the patients. Then there's something that's called spine hypertension syndrome. So what happens when there's an aortic cable compression going on? The heart rate increases as a compensation to decrease venous return. But if the aortic cable compression is not relieved, there comes a point when the heart rate starts decreasing, and so you get a difference in blood pressure from upper limb to lower limb. Then that's quite significant, and then you have a drop in heart rate. Okay, when that happens, we call it a spine hypertension syndrome, and blood pressure, just goes to the floor. It's quite terrible. So when that thing happens, you have to immediately turn the patient to the left side. Now, so these are the normal physiological changes. There are so many other physiological changes in pregnancy, but I'm not going to go into detail about all of them. I'm just going to I will, keep my presentation, and I will just be concerned about the physiological changes that happen with as well as from the cardiac point of view, not from everything. So before we actually go forward, it's very important to stratify these patients as according to their risks. And there are so many scores for risk stratification. I'm sorry about this slide. This is one of my ugliest slide of this presentation. I don't really like it, but I can't help it out because I had to present one score. So there are three scores. And there is a CARPAC score, Zahara score, and then there's a modified WHO risk score, and that is the WHO risk score that's tell you something about it. I'm not gonna tell you everything what's written on the slide, but so there are four classes in the WHO risk score: 1, 2, 3, and 4. And in what I'm going to be particularly concerned about is the WHO risk class 2 as well as WHO risk class 3, because these are the patients that need most of our attention. I mean, if somebody is in WHO risk class 4, that should not be pregnant in the first place, you know? Anyway, so for in the risk class 2, the risks are pregnancy is the patient that falls into the risk class 2 is somebody with a smaller multiple stenosis, PDA, mitral valve prolapse, VSD or ASD corrected, repaired coarctation, mild LVH, that sort of things. So it's why it is important to stratify the risk, because where these women are gonna be managed depends on the risk. So somebody with the risk classification of 2 or 3 is managed by the obstetric anesthetist in the delivery suits, while somebody in the risk class 4, if that gets pregnant, then they will be managed by the cardiac anesthetist in collaboration with the obstetric anesthetist and obstetrician, but in a cardiac CIC and CCU. So that's important, okay? The other thing is, for risk class 4, they are extremely high risk of maternal mortality or severe morbidity. And so they should not getting pregnant, I told you in the first place, but so there should be discussion with them whether they want to continue with the pregnancy or not. Okay. In risk class 3, these are the patients that should be done as preferably as elective by a consultant and a specialty registrar during the morning. And the condition that can occur and that are included in risk class 3 are mechanical wall, systemic, right ventricle, Fontan circulation, stenotic heart disease. But I think I have done all those conditions, all those cases in the night. I mean, it's a tertiary hospital, so one has to know and one has to deal with all those cases around the clock. For risk class 4, so these patients sometimes, we do. If a patient like in risk class 4 that happens, we tend to do them as a 2-in-1 operation. So we do the cesarean, get the baby out, as well as correct the cardiac lesion in them as well, right at the same time. Okay, but the focus of this presentation would be somebody in risk class 2 and 3, not in risk class 4. So before moving forward, etiology of all the valvular heart disorders is a congenital disease, and by congenital disease, I mean bicuspid aortic valve disease, and this is the most common reason in the resource-rich countries. Rheumatic heart disease is the most common cause of valvular heart disorders in the resource-limited countries, and then infective endocarditis. And now, so that's an important thing. So that's an important concept over here. So left-sided lesion versus right-sided lesion. So as a rule of thumb, it is the left-sided lesion that is more dangerous than the right-sided lesion, just because most of the cardiac output and the systemic circulation that arises from the left side, not from the right side. Then the other thing that's quite important concept over here is what's more dangerous? Is it a regurgitant lesion or is it a stenotic lesion? So the stenotic lesions behave badly, quite badly during the pregnancy, while the regurgitant lesions, they get ameliorated. I mean, the condition gets alleviated, it gets improved during the pregnancy. So pregnancy in the whole cures the regurgitant lesions, just because, the regurgitation depends upon the heart rate. If the heart rate is slow, there's more regurgitation, but in pregnancy, it's a state of tachycardia. There's already a physiological tachycardia, so there's less time for the regurgitation to occur. So the regurgitant lesions are very well tolerated during the pregnancy, and there's nothing much unless and until there's a heart failure associated with the regurgitant lesion. Other than that, I mean, these pregnant patients will fare quite better. talking about the stenotic lesions, so what happens in stenotic lesions? There's a rapid increase in the cardiac output in the pregnancy, as we talked about earlier, and that when that happens across the stenotic wall, increases the transvalvular gradient, and it leads to higher upstream pressures and significant wall stenosis, then limits the heart's ability to increase cardiac output during pregnancy. So, for any stenotic lesions, the hemodynamic goal should be to slow the heart rate and increase the blood pressure. Okay, and that goes down in the pregnancy. The blood pressure goes down while the heart rate goes up. So, pregnancy in that state deteriorates the stenotic lesions. Okay, so that's the basic concept. Now, we will talk about aortic stenosis. So, there are two conditions. So, any left-sided stenotic lesion from the last of my discussion, you can easily deduct that it a left-sided stenotic lesion is going to behave terribly in pregnancy, and that's what we should. I mean, if we get any left-sided stenotic lesion, our eyebrows must be raised, and we should give quite a lot of attention to these disorders. So, talking about one of the first left-sided stenotic lesions is aortic stenosis. And it may become symptomatic for the first time during pregnancy. It's quite normal. I mean, a person could not show any symptoms of aortic stenosis before pregnancy, and they could show the symptoms for the first time during the pregnancy. Heart failure occurs in 10% of the women with the severe disease in aortic stenosis, and arrhythmias occur in 3 to 5%. There are three types of aortic stenosis: valvular, supravalvular, and subvalvular. I will discuss about what are those things. And etiology this time, I think we discussed about etiology already. So what's valvular? So valvular is it's the stenosis of the wall. When you say subvalvular, so it is the prevalvular area, the annulus area that gets stenosed. And when I say supravalvular, it is the postvalvular area that gets stenosed. So what will be the symptoms? The symptoms are dyspnea, syncope, angina, then the signs of left ventricle failure and that. But the dyspnea is, one can argue that I told that dyspnea is a normal physiological change. So what's the difference? So a dyspnea that occurs at rest during the second trimester or during the third trimester. So if a patient is dyspnea at rest, that's a red flag sign. Okay. Then the signs: a slow rising pulse, and you can see there is also an ejection systole in mercury, but it's not physiological because it's on the right sternal edge instead of the physiological murmur that occurs on the left sternal edge. And the other thing is, it occurs at the right sternal edge and radiates to the carotid arteries and the apex. So what are the investigations that we would like to do? We would like to do ECG, and it will show signs of LVH, but one they can say that, LVH, as you said, LVH is normal, but you will find moderate to severe LVH, and then you can find signs of ischemia and lateral ST segment strain pattern, and then the important point I will stress on this point is, if you find a patient with aortic stenosis or a mitral stenosis, you have to do that chest X-ray. Yes, the radiation causes hazard to the fetus, but you can shield them. So the fetus can get shielded, but it's so important to do chest X-ray in left-sided stenotic lesion. You really want to do it. You want to see the signs of cardiac failure and cardiomegaly. And then echo is quite important in those patients. And why is it that important? It's not important to see pressure half time and transvalvular gradients. So in echo in pregnancy, we are concerned about the valve area. No matter if it is an aortic stenosis or the mitral stenosis, just because the pressure half time and the transvalvular gradients they're going to be misleading, because of the physiological changes that have occurred during the pregnancy. But the valve area is going to be the same. It's going to remain constant, and that's an important prognostic factor as well as a factor to assess the severity of the disease. The normal valve area is 2.6 to 3.5 centimeters square. Mile AS is greater than 1.5, and moderate disease is 1 to 1.5, and the severe less than 1. I'm not going to go into detail about the staging, of aortic stenosis walls. So they stay A, B, C, and D, because it will, drift from obstetric anesthetist point of view to go more into the cardiac anesthetist point of view. And I don't think so that will be very relevant, and the presentation could get, just away from the main topic. So I will just leave it over there, and we'll go towards the management. So medical management is quite important in aortic stenosis. You have to get this tachycardia under control, and to do it, you have to use beta blockade. You can use calcium channel blocker. We don't really use that in our department. And in terms of beta blockade, we use bisoprolol. We don't use metoprolol over here. Okay, and if you see the signs of cardiac failure, you have to use diuretics. The type of diuretic that you have to use, it depends on the blood gases, UNEs, urine electrolytes, all those things are factored in before doing before making a choice of diuretics. Then these women should have bed rest and oxygen therapy, so they enable a woman to reach a more desirable gestational period. Surgical intervention can be done for the patient that are not respond to the medical treatment, and if that is done, it should be done in second trimester. And the treatment that we offer is percutaneous valvuloplasty, and aortic valve replacement is done as a last resort, but it is mostly done at when this patient is scheduled for GA section. Okay, aortic stenosis management. So vaginal delivery with assisted second stage and early slow incremental epidural is the preferred option. So if a patient with aortic stenosis comes, so it's better to give them an early epidural. That's what we do, and then we don't want to decrease the SPR too much, so we give boluses slowly, and then the standard of care is continuous monitoring with ECG, oxygen saturation, non-invasive blood pressure. And for a patient with labor, if it's WHO class 2, then we will leave the A line. But if it is a WHO risk class 3 or 4, then we have to put the A line. And hemodynamic goals are avoid aortic cable compression, maintain the sinus rhythm, avoid tachycardia as well as bradycardia, maintain SPR, don't let the SPR fall, maintain the venous return and left ventricle filling, keep them well fed but not overfilled, keep them good pain relief, and they are most probably managed postnatally in HDU and ICU. If those women come for a C-section, C-section is mostly undertaken for severe disease, especially with the symptoms in the third trimester. The hemodynamic goals are the same, but the only different record is the A line, the invasive monitoring is essential. So you have to put the art line in. We are not very fond of putting central lines in these patients or any patient. We like to do the art lines, but not the central line. And the other difference that occurs is you don't have to give Sint as a bolus, because of the Sint to drive the heart out, it will cause tachycardia. So what we do is we give them a Sint as an infusion of 2 to 5 units over 330 minutes, and no more. We just have to say no to augmentin and copperprost. You can use GA, CSC, or epidural, but in our department, CSC is the standard of care. So we use combined spinal standard epidural. We put a spinal and just give 1 mil of 0.5% before again, just 1 mil, and then so we do the epidural at a separate space, and then a spinal at a separate space. So the epidural is in, and we test the block height. If it does not reach the required level, then we just can just top up the epidural, and there's already a phenylephrine that is prepared and that is attached. So as soon as the spine goes in, we just start the phenylephrine. In the case of GA, so you have to use high opioid at induction. So you have to use alfentanil. I will not use remifentanil first, because we usually give GA in the case of there's a Cat 1 section, so category 1 section, and there's not enough time for remifentanil to be drawn and made. The other thing is Remi causes bradycardia, and the bradycardia is quite severe. So alpha is good enough, fair enough. And then if you have put them to sleep, then we can use transitional echography, and these patients are managed postoperatively in HDU and ICU. So some heavy teaching going on, so you just relax and just see. This is my hospital. Uh, so on every Thursday night, we have a clap over here, and this is the clap that occurred 2 months ago. And just because there's so many uh, doctors from South Asia, mostly from India, and in this hospital, so the residents got a dole and they played it just to get our morale boosted in this COVID times. Okay, just to cheer up. I think. Let's
डॉक्टर
move forward.
जाहिद, ये कोरोना से पहले क्या इवेंट ये होगा?
So during the corona.
Okay, then.
Yeah, it's so it's a Thursday club that occurs on every Thursday.
Good.
Your neighbors and the whole nation comes out of their house and claps for the NHS, claps for the doctors. But that's
Good.
something that's been occurring since March. And I think a month back, somebody want to cheer up the foreign doctors that are working in this hospital. So they got a dole out, and so I just finished my long day morning shift, and I made up this video anyways. So we're going back to the mitral stenosis. So that's the second most important topic, in this presentation, mitral stenosis. And the women most at risk include the women that have moderate to severe MS. And what's a moderate to severe MS? I will discuss about it in the next slide. The women, we have significant pulmonary hypertension. So, and then the women that have a symptomatic heart failure that typically occurs in the second or third trimester. And if we're using modified WHO risk scoring system, so any woman that fits into the risk class 4, that's a high risk pregnancy. And these are to be dealt in cardiac, by the cardiac anesthetists in collaboration with obstetric anesthetists if they are in WHO risk class 4, okay? Etiology is just the same, in research countries, the etiology is mainly acquired. It's due to rheumatic, and then it can occur to tuberculosis, but anyway. So what happens in mitral stenosis, it decreases the cardiac output and sets off a chain of very devastating possible outcomes, So the left atrium gets dilated. Whenever the left atrium gets dilated, there's a risk of having an AF, and just because, and it can lead to left atrium thrombi. There's risk of, and then the pulmonary hypertension can ensue. In severe cases, it can lead to right ventricular hypertrophy, and then the dilatation will follow. And just like aortic stenosis, same goes for the mitral stenosis as well. It can be diagnosed for the first time during the pregnancy. And then women complain of system of left heart failure. So, dyspnea, stress, syncope, chest pain, all those things. And if there is a symptom of hemoptysis in a patient, that it can be due to the pulmonary hypertension, okay? And then it could present with the following signs of the right heart failure, which include peripheral edema, perfusion, hepatomegaly, ascites. If we examine those patients, you can find a mid-diastolic rumbling murmur, left-sided and left-sided congestive cardiac failure. So all those findings you can have in MS. If we look at the ECG, in those patients, you can find bifid P waves. We already know these are P mitral, and you can also find a tachyarrhythmia or atrial fibrillation. Again, you have to do a chest X-ray to reveal pulmonary edema within a enlarged left atrium. So if the left atrium is enlarged on a chest X-ray, that's not a good thing. And then again, echo will be used, and I told you, so it's a valve area that we are more concerned. So normally it's 4 to 6 centimeters square, and anything less than 1.5 centimeters square is going to raise your eyebrows. And then the pulmonary hypertension, they are just used, or the degree of gradient uses prognostic indicators. So again, you can just figure out that the treatment is just it's about the same as aortic stenosis, but this condition, mitral stenosis, um, is more sorry is more grave, and it's more severe than aortic stenosis. So you have to use beta blockers to treat the tachycardia, and then the atrial fibrillation. Just because in these patients they are dependent upon the atrial kick to get to the pump adequate blood to have an injection, a good ejection fraction. So they depend upon the atrial kick to get good volume out. So atrial fibrillation should be treated aggressively with digoxins. Sometimes we give them IV digoxins, and then if none of that is working, then we have to use DC cardioversion. Diuretics should be used for fluid overload. In MS, you have to decrease the fluid overload. So there should be, and I talked about there's an autotransient kind of thing that occurs at the end of the third state of labor. In order to prevent the fluid overload onto that state, so what we can do is we can give them a shot of diuretics over there. Then thromboprophylaxis is quite important for atrial fibrillation, and then very best and oxygen therapy. Um, Anybody in risk class 3 that's not responding to medical treatment, she can be offered percutaneous balloon valvuloplasty or mitral valve replacement. So if that woman comes in labor, then if it's an AHA class 1 or 2, there's no pulmonary hypertension. That's important. So they can go normal vaginal delivery. What we like to do is we like to give them early epidurals. We would like to monitor ECD continuously, oxygen saturations, um, and non-invasive blood pressure monitoring. But for anybody in severe disease, we like to go uh, put an outline right away and do invasive monitoring. So physiological goals for these lamps should limit the increase in cardiac output, and then SVR should be maintained. So we'd like to do it with phenylephrine infusion, and then prevention of fluid overload. I told you that we like to give them a dose of diuretic just before the third state of labor to prevent the effect of autotransfusion. And venous return should be maintained by aortic cable compression, should by relieving organization, but excessive fluid should be avoided, and the tachycardia should be prevented, and the AF should be treated promptly. And the factors that can increase pulmonary hypertension or hypo, or hypercarbia, so give them oxygen, and then acidosis. So if we don't like to sedate them, because if we sedate them, it will take the respiratory compensation of pregnancy in itself is an alkalotic state. We like to keep it that way, and yes, we don't want them to be hypoventilating by sedating them, and then it can lead to having devastating sequelae. So if a patient with MS comes for a C-section, the things that we will do differently is first, if it is a moderate MS, the literature says that you can't give them spinal, but in our experience, we give them a combined spinal epidural. We just give them 0.9 to 1 mils of spinal, and then titrate the rest of the block with the epidural, and give the slow epidural until the block reaches the height of T4. And invasive monitoring is essential. So, and the saint and everything else is just the same. If that patient comes for the GA, then so it's going to be the same technique as we did it with AS, high opiate bolus and all those things. So mitral regurgitation and aortic regurgitation, I'm not going to go into a lot of detail about these disorders. So unless and until there's a heart failure, a diastolic or systolic, significant diastolic or diastolic dysfunction associated with mitral regurgitation or aortic regurgitation, other than that, these patients are fairly normal. If there's no arrhythmia, if there's no sign of heart failure, then you can just treat them as normal, okay? And by normal, I mean give them early epidural, and I don't overload them or underload them. Maintain the sinus to them. Don't give them a St. Bolus, all those things. and I mean they were quite better. Now, will come to the third and the most important. The third and most important. Why I say it's the most important because in the UK last year, 3 women died because of the complication of prosthetic heart valves. So the 7%, out of those 7%, 3% of the women died because of the complication of prosthetic heart valves. And prosthetic heart valves can be because of they are made of tissue or they can be mechanical. So for the last 15, 20 years, we are in UK, we are using biosynthetic heart valves, not mechanical ones, because those ones are, mechanical ones are associated with a lot of complication. Tissue walls are well preserved and the cardiac function fares better with them. And there is lower rate of wall thrombosis and they don't generally require anticoagulation. But the problem with them is they are less durable and they get damaged due to tissue degeneration, And for the mechanical walls, then they have to be, the problem with them is hypercoagulability that risks the mechanical wall thrombosis, and their mortality is quite high, 1 to 4%. When you have a patient with prosthetic heart valve, the most important thing to do is cardiology referral. And then the two important topics when you discuss with the prosthetic heart valve is antibiotic prophylaxis and anticoagulation. We don't, unless until there is a history of infective endocarditis or anything like that, we don't routinely give them prophylactic antibiotics, but we do discuss it with the micro team. And I mean, from with microbiologists, so for the prosthetic heart valve, it's going to be a MDT approach. And yeah, micro should be on board. And if the macro guys are happy, we just don't give them any antibiotic prophylaxis. So anticoagulation, it's controversial subject in case of the prosthetic heart valves, just because there's no consensus in the world on that. Uh, it's quite a detailed topic, just because in anticoagulation there are warfarin, but there is a risk of bleeding from the placental bed, and then the risk of fetal loss, and just because there is a risk of embryopathy with warfarin in the first trimester. So we follow European Society of Cardiology guidelines, and and what we do is we classify, if somebody is on mechanical valves, we classify into high risk and low risk. And by high risk, I mean somebody that's on older generation of mechanical valves that's been put in tricuspid position and has atrial fibrillation or history of TE on heparin. And if there's somebody, and by low risk, I mean somebody with the new generation of mechanical valves that are put in mitral position or in aortic position. So if it's somebody is on high risk, the only difference between risk stratification is whether we give them aspirin or not. That's the only difference. Other than that, if somebody is on warfarin and the dose is less than 5 milligrams daily, they can be continued, but the risk should be discussed, that these are the risks to the baby and risk to the placenta and risk of bleeding. The target INR that we use is 2.5 to 4, and APT should be done 4 to 6 hours after subcutaneous injection, twice the control value, and we maintain the anti-tennis. So anybody on warfarin or lower molecular weight heparin, so warfarin is discontinued at 36 weeks, and after that we just put them on unfractionated heparin or lower molecular weight heparin, and we tend to like to keep the anti-10 levels at 0.8 to 1.2 units per mil. Okay, so that's the target. That comes to the end of presentation. I extensively used chestnuts, the 2006 edition that just came out this year, for making this presentation. I know it's not comprehensive, but it's like any other presentation, so it should be succinct and brief. And then there are very good articles about from BGA, and one of those articles, the Bishop L, that's from my department, and Dr. Alison Lansbury, one of the consultants working over here, she's a co-author over there. And then that's a very good article to read about it. If anybody wants to learn about valvular heart disorder in quite in detail, I have all those resources, I have all those articles, and can just share it with all of you guys. Thank you very much. I'm just gonna end my presentation over here and just give you, that's it.
Mm. Thank you so much, Dr. Furqan. That was an excellent presentation, and especially the guidelines and practice and your routine work that actually helped your trainees in a sense to manage these patients. Now we have uh, some time regarding the questioning of our participants, and another first one, Dr. Shafi want to ask the question. Dr. Shafi,
Yes.
unmute your.
Hello.
जी जी करें आप
Hello.
जी
Assalamu alaikum, sir.
Walaikum salam wa rahmatullahi wa barakatuh.
Sir, this is Dr. Safiullah. Sir, I'm thankful to
Ah,
you that on special on
Shafiq.
my request, you you just prepared the lecture. Though I was requesting Sir Saqib that you would give the lecture to
MashaAllah,
us.
Shafiq.
But nice to thankful to Dr. Salam that he managed this forum for us, and the knowledge is sharing on so many forum. It would be shared further on. Sir, the presentation was very excellent, very crisp, and very helpful. I think if we apply this, then so many lives can be saved, because here in Pakistan, the epidural concept is emerging now. And still we use spinal and spinal anesthesia, in my opinion, and from your presentation, I got the lesson that if still follow the spinal, then the dose should be reduced.
No, it should be
Uh,
reduced massively, man. I mean, it should
yes,
be
yes,
one
yes.
third of your normal dose. One third.
Yes, yes, sir. Yes, sir. This is the point which should be conveyed to everybody. This is what the lesson I got from your presentation, sir.
Good.
That it should be at least till one or less than 1.8, 0.9, so that because the surgery could be done in C-section with this. Though epidural would be helpful in such sort of disorders like MS and AS, but it would be done later on, or if the patient's convenient and the physician are convenient, and is the teamwork, it could be done. Sir, again, once again, so much thankful to you that you spare the time, your precious time for us.
That's fine.
And
No, that's fine. That's fine. So,
sir,
I think verbal holidays are important, but as far as I say, I think it's ischemia and MI and ischemic heart disorder. That are very and then the aortic dissection. These type of topics. So these in UK, I don't know about Pakistan because we don't have any reliable data over there. But in UK, these are the most prevalent disorders. So I think we should have a teaching session on ischemic heart disease and MI or aortic dissection, how to manage those disorders during the pregnancy as well. So I'm happy that you gave me an opportunity to present, and you guided me on which what sort of people should be contacted. And I think, and I'm thankful to you that you facilitated me in meeting Dr. Arslan and then, of course, Dr. Amir Furqan. And so I'm impressed with this initiative. And you can talk to so many people and spread your experience, and I'm happy. Talking about the clinical question, so so it's so when you're dealing with a cardiac patient on the maternity ward, it's not a single person. Okay, you should not be involved right at the very end. You should be involved right in the first step when this patient comes into the maternity suite. So obstetrician should contact you, and then it's always good to put an early epidural. Because if you have put an early epidural, and then if that woman goes towards a C-section, you can just top up the epidural incrementally. Okay, you just need to, if the epidural is already there and it's working, you just have to top it up with the Privacaine incrementally, and just put a good IV access. And I talked about that. You have to put an outline. You can, even put an outline even in the labor of maternity ward, but I don't know what sort of monitorings over there. So if that patient comes to the theater, there's already epidural in. You can put an outline rapidly, and then you just there should already be an IV access, of course. You just because you did an epidural, so there should be an IV access. Yeah, so just put an outline and do the case then. The only thing that I want to focus is don't give them a St. Bolus, don't give them St. Bolus, and don't use preload or afterload. Don't use preloading or co-loading. That's out of the question. So there's no such thing going on as a preloading or co-loading in the Western world or anywhere else, in America or in Europe. We don't preload the patient for a section. We don't co-load the patient. It's not about the cardiac patient, but only over the other patient. We don't, just keep on giving them. 400 mils is more than enough because, the blood loss during a normal section is less than 500 to 600 mils, and these patients, when the uterus contracts, this 500 mils comes back into the circulation. So you don't just need to maintain their blood pressure, and you can do it with the phenylephrine and infusion, and that's what we do. If you don't have the syringe pumps, if you don't have the syringe pump, the only other thing that you can do is you can put 1 milligram of phenylephrine in a 1 liter of Hartmann and just run it. It will maintain the blood pressure. And just keep on titrating it with the clamp holder. You can do that way. Hope that answers your question.
Yes, that's excellent, and that is definitely a new dimension which we are just hearing about here. Where the usual practice in Pakistan is we consider it a must thing, go for preload. Without preload, no question about the spinal, and I think it's definitely very valuable information. And we have Dr. Tanveer Ahmed. He is also from UK, and I just want to get his opinion as well. Yes, Dr. Tanveer.
Yes, Dr. Zahid Furqan, Assalamu alaikum.
Wa alaikum assalam, rahmatullah wa barakatuh.
I'm from Lincoln County Hospital. I think we are 1.5 hours away.
Yes.
Basically, yeah, because our hospital is not the teaching hospital. Of course, yes. You are in university hospital.
Exactly.
Well, I totally agree with you regarding the loading of the patient, but we have to be on the ground realities. I worked in Pakistan. I trained there. Then I worked in UAE. Then I'm working here. It's not ground reality in Pakistan, for example. Yes. If you tell them not to preload, they will lose the patient. I tell you, don't do it.
But I'm saying that if you're not preloading, co-loading, you have to put you have to get a phenylephrine infusion ready and set up and start. And if you don't have even the phenylephrine infusion, then what you can do is you can put 1 milligram of phenylephrine in the bag and just keep it running slowly. But if you're not doing anything, then yes, you have to resort back to the old practice.
Yes.
Of preloading and co-loading. Yeah, you're right over there.
I would segregate this into is for routine section. There's no harm. You have a Hartmann running and you give spinal.
That's fine.
Because you got a patent line and you can easily manipulate.
Yep.
Even here, many patients, although we allow the sip of water till the last moment. Okay, you can take water, that's fine. But many patients still, they are fasting too long. And if you don't have a good line and running drip, there's a massive, very quick hypotension and you are in very big trouble. Having in mind, we don't have any syringe pumps and phenylephrine infusions running in Pakistan. And they are only running on the IV drip and the intravascular volume. So while sitting here, it's not ground reality. Yes, in valvular heart lesions, okay, you don't do it because that needs a careful preparation and full focus. At that time, you arrange your drug and everything. So my advice would be for routine section, like 95% of our practice is routine section. You go ahead with the standard thing, having a drip running, it will not harm anyone. By the way, we are hot countries. We do have a lot of
I agree with you.
But yes, I completely second your advice in valvular heart lesions where there should be no overloading. Then yes, you don't do prepare everything very carefully, drugs, syringe pumps, and everything. Then you have to be on your toes and thinking and doing. I
Yes.
mean, I
Yes.
want
Yeah.
to refine it.
Yeah. Yeah. Refine. Thank you. Thank you very much. Thank you for doing that for me.
Yeah,
Just
that's very
because
nice.
I always deal with the neuro patients and the cardiac patient. Jim is that unit that are aware work. So always have the patient with pre-morbids. We don't have any routine patient, that doesn't have any pre-morbid in this unit. I mean, you're always dealing with cardiac patients. So that's just, that changes you, the way you think and the way you approach to a pregnant patient. So I second you that if it is a routine case, yes, you can continue with that practice. Okay, that go with the fluid preload, a co-load, and yes, and do a smile. I mean, so in those patients, that's not a concern. Yes, it's only the cardiac patient that are important, and for those patients, we have to treat the balance. And similarly, I mean, it doesn't end over there. Even if you have, I mean, if the obstetrician asks for a syntenfian, for a cardiac patient, we make it into in a 40 or 50 mils syringe. So even and you don't give them the saint in a 500 mils bag, just like you do it for a routine pregnant patient. You know what I mean? So for a routine patient, I mean, a patient that doesn't have a cardiac premorbid, if that asks for a scent, I mean, the obstetrician asks for a scent infusion to be running, what you would give, you put 40 units in 500 mils of bag and just run it at 10 units per hour. But that doesn't happen for a cardiac pregnant patient. We put it into 40 mils of syringe or 20 mils of syringe, and just to decrease the volume of the fluid. But I absolutely second the first part that you said, that for routine, I mean, for a normal patient, a normal pregnant patient that doesn't have any premorbid, it has to be done this way. And I completely second you and thank you for correcting me. Cheers. Thank you very much. Thank you very much. I can't hear you, Dr. Ahmed.
Your practice regarding the induction with opioid, उसमें पाकिस्तान में तो हमारी रूटीन ये है कि हमें अवेलेबल नहीं होता इतना ओपियाइड फॉर इंडक्शन, कार्डियक सेंटर्स में भी है, तो उसमें हमारी जो यहाँ परसेप्शन है जिस पे हम थोड़ा डरते हैं, ये अगर इफ वी आर इंड्यूसिंग द पेशेंट विद ओपियाइड इट माइट हैव इफेक्ट ऑन बेबी एंड
And
वो
it does have.
आपकी एक्सपीरियंस में कैसा है, उसमें ये इफेक्ट आ रहा है या?
Yes. So I mean, if it's a GA, so GA is only reserved for patients that are very, the first, if they are very severe, so they will be risk class 4. And so, I mean, WHO risk class 4 mostly be done in the cardiac theaters, and they will go on pump then, so, I mean, so, I mean, those category 4 patients are these are the ones that can't tolerate CSE as well. And so, and I talked about this, that on those risk class 4 patients for which you have to give GA, the first thing, they should not be pregnant in the first place anyway. But if they are getting pregnant, so it's the cardiac anesthetist and the cardiac team. The obstetric anesthetist is there's a consultant obstetrician over there, but he's not the one calling shots, and it's the cardiac anesthetist that's calling the shots for his category 4. The other thing that can occur is a GA for a Cat 1 section. So it's an emergency section, and you don't really have the time to do a CSC. So yeah, so you will have to give GA for that as well. Just because GA is a bit quicker. In those patients, what we do is you have to give good opioid. That's for sure. Okay, and yes, the baby. So it's all those things that you have to prepare everything before giving the GA. You have to catheterize the patient, prep it up. The pediatric team should be ready. They should be told that I'm going to give a high dose of opioid, and then so preferably a senior pediatrician with a junior one should be ready to assist the baby. And yes, from the onset of giving the drugs, we give them 3 minutes to get the baby out, and she should be ideally out by 5 minutes, not more than 5 minutes. And yes, so it depends on all those things. But even the baby is crappy, and they can just such days that the pediatrician can assist it. The neonatal doctors are over there. They're already standing. They're already waiting. So yes, that's the way it is. But we have to give good OPI. The other thing, if you don't have L-fentanyl over there, the other thing that you can do is you can give lignocaine to blunt the pressure response, but it will not give you a good analgesia. I didn't talk about, so GA for a section, the way we do it is, that's a whole presentation in itself, Post-operatively, then there is then you have concerns regarding pain. And what we do is we give ultrasound guided tap blocks, but I'm not very fan of tap blocks. I like to give rectic sheath blocks because rectic sheath blocks are easier to do, number one. Number two, they give you better post-op pain relief. As compared to tap blocks, there's more hit and miss with them as compared to rectic sheath blocks. So, yep. So that's on the pain side of things. I'm sorry. So coming to your original question, yes, there's a concern of neonatal bradycardia and fetal distress with that, but we have to realize that in those scenarios, it's the mother's life that is important as compared to the fetus life. So that gets the priority as far as the obstetricity is concerned. So the mother should be given the priority, and of course the fetus. I mean the neonate, it can be resuscitated. You can give Novavax and so many things. I mean, neonatologists are quite good at that. But I mean, so that's the it is.
Definitely. Anyone have question? We have 5 minutes to go. Dr. Jahangir. Yes, unmute yourself. डॉक्टर जहांगीर आप अपने आप को अनम्यूट करें. No problem. Yes, Dr. Tanveer want to say something.
थैंक यू.
अस्सलाम वालेकुम सर.
सर तनवीर भाई ये ले
मैं
ले.
बोलूंगा.
जस्ट मैं आपको थोड़ा सा होल्ड करूंगा. जहांगीर को क्वेश्चन कर लेने दें. जी जहांगीर करें अनम्यूट अपने आप को.
थैंक यू सर, थैंक यू सो मच. अच्छा सर, मैंने पूछना था कि सिजेरियन के लिए हम कीटोडेक्स और कीटोफोल यूज कर सकते हैं, क्योंकि हमारे यहाँ प्रैक्टिस है कि हम नेल्बिफ्रिन को अवॉइड करते हैं. उससे लो एबगार स्कोर का रिस्क होता है कि एबगार स्कोर लो होगा. तो मैंने ये क्वेश्चन करना था, ऐसे माइंड में आ गया.
ये डेक्समेटोमिडीन एंड केटामिन कॉम्बिनेशन एंड केटामिन प्रोपोफोल कॉम्बिनेशन.
So if you talk about that choice of direction, that's what I thought. I told you that this is a whole discussion in itself. There's a difference in opinion about the choice of IV drugs, even in that trust. So I told you that there are two parts of Jimmy's optional. One is that one that deals with cardiac and neurological patient. The other one deals with the respiratory problems and the hematological problems. So I work in LGI, and in LGI we like propofol, and in the cardiac patient we like to use thiopentone. Why? Number one, but thiopentone, the dose is fixed. I'm only giving GA for the speed. Okay, so if I want speed, I want to give a fixed dose that doesn't decrease the heart rate a lot. Okay, and the other thing is it's a fixed dose, so you can just calculate it in terms of weight, and give it shot, and it will start working. In case of propofol, what happens is the dose is not fixed. You have to see the patient's response. So, and sometimes you give it, and then you're a risk. And then you're thinking about the blood pressure that's falling. You're seeing it on the outline, and so you keep on titrating that way, and it takes a bit of time. So we're not very fond of propofol in cardiac patient for a GS section. You can give it. And then talking about ketamine, ketamine causes tachycardia, and tachycardia is not well tolerated. It it's not my aim in case of stenotic lesions. So I will not like to give ketamine. And then increases pulmonary hypertension as well. That's another concern. So ketofol, it's balancing the risk, but why don't we give etomidate in the first place? The other thing that that's important that you can give is etomidate. So you can have etomidate. I think that's available. I use etomidate when I was in Pakistan. It's available in Pakistan. So etomidate it's good. And thiopentone is quite good. So if you have those drugs available, and then why are you using? I don't know. Why should we use ketodex or ketofol? Because the effects of propofol are not good, and then the effects of ketamine in valvular disorder are not good at all. So I would not like to give. If I would not like to give ketofol or ketodex. Talking about opioid. Yes, that's one of the problem in Pakistan. You can give, you should give good opioid, and if you're not giving good opioid, I think Dr. Furqan himself is a cardiac institute. He knows that for a cardiac patient, you have to give good opioid. There's no alternative to it, man. And then I just said that it's the woman's life, mother's life that's important than the baby's life. I'm not saying that the baby life is not important, but in those conditions when you have to make a judgment call, then you have to err on the side of the mother rather than on the side of the fetus.
डॉक्टर फुरकान और डॉक्टर तनवीर दोनों से ये मेरा सेम क्वेश्चन है कि हैव यू एनी एक्सपीरियंस ऑफ यूज डेक्समेटोमिडेन इन ऑब्स्टेटिकल पेशेंट, नॉट स्पेशली इन कार्डियक पेशेंट, इन नॉर्मल पेशेंट? कोई एक्सपीरियंस आपका उस पे हो सेफ्टी वाइज?
No, so dexmedetomidine is not available in UK. It's not available in my hospital. So we haven't used it. We haven't used it at all. Okay. I used dexmedetomidine when I was in Pakistan. I used it in Pakistan, but that's not available in my center. So I have no experience of using it in these cardiac patients.
तनवीर भाई, इसमें इसकी सेफ्टी पे कोई डिबेट हुई हो आपकी तरफ के ऑप्स के पेशेंट में सेफ है कि नहीं है?
यूके में डेक्समेड है नहीं, इधर भी जैसे गवर्नमेंट का सिस्टम है ना पाकिस्तान में, इधर भी ऐसे ही एनएचएस गवर्नमेंट ही है, तो जब तक वो कोई चीज की बहुत अच्छा बेनिफिट क्लियर ना हो जाए वो नहीं आती. बट वी यूज्ड दिस ड्रग मैसिवली इन दुबई. उसमें स्पेशली ये जो सर्जरी है बैरियाट्रिक सर्जरी, स्लीव गैस्ट्रेक्टमीज और ये सारी होती ही इसी पे थी. और उसके बाद पीडियाट्रिक में हमने इसे यूज किया, पीडियाट्रिक सर्जरीज में. लेकिन सिजेरियन में look, 99% of cesarean are straight away in regional anesthesia. उसमें कोई एक आध जीए में अगर सेक्शन होगा तो ओवरनाइट कोई कैट 1 सेक्शन आ गया है, कोई प्रोलैप्स है या कोई सीवियर, ओनली देन. बट वो होता है आउट ऑफ आवर, उसे हम कहते हैं कि जी वो इसके बाद है. लेकिन उसमें देखें डेक्समेड जब तक प्रिपेयर होता है आप तब तक उसकी सारा कुछ जीए वही सीवोफ्लोरिन और सारा कुछ.
Give the regional that much time.
Yeah.
वो उसमें ना मुझे इस पे बड़ी कंफ्यूजन हुई है. हमारे बड़े सीनियर एनेस्थिसिस्ट हैं, उनकी एक प्रेजेंटेशन मैंने सुनी, उन्होंने प्रेजेंट ये किया कि आई यूज डेक्समेटोमिडेन सेडेशन विद स्पाइनल. वो उनकी ये रूटीन है. अब बहरहाल उनकी लॉजिक मुझे समझ में नहीं आया. उस पर मुझे भी ये कंफ्यूजन थी कि इसकी सेफ्टी रिगार्डिंग ऑब्स्टेटिकल पेशेंट्स. और अब पाकिस्तान को तो आप जानते हैं कि स्पाइनल देने से पहले सेडेशन दे देते हैं और बाद में कहते हैं जी कि हमने जीए में करवाया. उस तरह के सिनेरियो में ये प्रैक्टिस डेवलप हुई
नहीं. रीजनल में व्हाट इज द यूज ऑफ गिविंग रीजनल एंड देन सेडेटिंग? व्हाट इज यूज ऑफ
वो डॉक्टर तनवीर, उसका लॉजिक ये है कि व्हेन सर्जन जो है वो जो बुक्ड सर्जन है उसकी जगह पे कोई और कर रहा है तो पेशेंट इज सेडेटेड, पर दिया हुआ उसे स्पाइनल है.
ये गलत है ना. ये देखें मॉरली गलत है, एथिकली. अगर कोई पेशेंट को एजुकेट आपने करना. अगर कोई पेशेंट चाहे कि मैंने अपने बच्चे को देखना है कि कब वो पैदा हुआ था, मेरी मेमोरीज और
वो तो आइडियली यही है कि
उसके बगैर ब्लंट कर दिए हैं, तो ये तो
जरूरत नहीं. तो अब उसमें मेरे ज़हन में जो साइंटिफिक पॉइंट था कि वेदर इट्स सेफ कि देना भी चाहिए, क्योंकि वो है तो ये अनएथिकल ना, ये तो प्रैक्टिस अनएथिकल है. मैंने उनसे क्वेश्चन भी ये किया तो उनका आर्गुमेंट ये था इट्स सेफ. انہوں نے 1-2 آرٹیکل بھی اس میں شیئر کر دیے, بس ان کی اتھینٹسٹی اتنی اچھی نہیں تھی, کوئی اتنے اچھے جرنل نہیں تھے. تو آئی ہیو کویسچن کہ اس کی تو ابھی سیفٹی نہیں پروون ہوئی. سو آئی
بس
تھنک
دیکھیں اس کا انیسٹھیٹک پریکٹس جو ہے نا, دیکھیں ادھر بھی اب میں کیسے ایکسپلین کروں, آپ نے بس پیشنٹ کو بتانا ہوتا ہے کہ وہ کیا چاہتا ہے, آپ کا کام ہے اسے ایجوکیٹ کرنا, اس کے بعد اس کے اوپر ڈیسیژن چھوڑ دینا. ایگزامپل آپ کو دیتا ہوں, اگر فائنل میں سیزیرین ہو رہا ہے, پیشنٹ کو ڈسکمفرٹ ہو رہی ہے, اب ہم فوراً پاکستان میں اٹھاتے ہیں سیڈیشن یا کیٹامین یا کوئی نارکوٹک اسے دے دیتے ہیں. یہاں غلط ہے یہ. آپ پیشنٹ, آپ سرجن کو کہیں گے رکو بھائی, پیشنٹ سے ڈسکس کریں گے کہ آپ کو ڈسکمفرٹ ہو رہی ہے, 2 آپشن ہیں, آپ چاہیں تو میں آپ کو نارکوٹک دیتا ہوں, آپ کا پین کافی بہتر ہو جائے گا. دوسری چیز ہے آپ کو جنرل انیستھیزیا کی میں آفر کرتا ہوں, آپ کیا چاہتے ہیں. اگر پیشنٹ کہتا ہے مجھے جنرل انیستھیزیا دو, تو آپ نے جنرل ہی دینا ہے اس کو. بس اسی بات کے اوپر ہمارے ایک کنسلٹنٹ کی پیشی ہو گئی تھی کہ اس نے سیزیرین میں پیشنٹ کو ڈسکمفرٹ تھا, اس نے نارکوٹک دیا, ہفتے بعد اس کا لیٹر آ گیا کہ بھائی عدالت تشریف لاؤ. پیشنٹ کہہ رہی ہے کہ جی مجھے تکلیف ہو رہی تھی اور اس نے پتہ نہیں مجھے کیا دیا اور میں تو اس سے بڑی پریشان ہوں. آپ نے بس پیشنٹ کو بتانا ہے کہ یار ڈسکمفرٹ ہے آپ کو, سرجن رکے, کیا چاہتے ہیں آپ. وہ کہتی ہے اٹس آل رائٹ, جسٹ گیو می اے پین کلر اینڈ لیٹس سی. آپ نے دیا, وہ کہتی ہے اٹس آل رائٹ, اور سرجری کے بعد میں آپ نے اس سے 2-3 گفتگو کر لینی ہے کہ سوری آپ کو تھوڑی تکلیف ہوئی, لیکن ہمارے پاس جو آپشن تھے میں نے آپ کو دیے, اگر آپ چاہتے تو میں جیے دے دیتا. ایٹ دی اینڈ ہم غلام ہیں مریض کے میرے بھائی, کسی اور کے نہیں. غلام اس لیے کہ جو پیشنٹ کی انکم ہے نا, اس کا نیشنل انشورنس سے, جیسے پاکستان کی عوام ہے ان کے ٹیکس سے ڈاکٹر کو پیسہ جا رہا ہے, تو وہ کہتے ہیں کہ یار ہمارے ٹیکس سے آپ ملازم ہیں, تو بس ہمارے سیدھی سیدھی بات کرو. سو واٹ.
تھینک یو,
ٹھیک ہے.
تھینک یو ڈاکٹر زاہد. جسٹ گوئنگ ٹو کلوز اینڈ ایکسیلنٹ پریزنٹیشن.
سر 1-2 کوشچن یہاں پہ لکھے ہوئے آ رہے ہیں, ان کو شاید ڈسکس کر دیں. شاید ایک کوشچن لکھا ہوا آ رہا ہے چیٹ میں, میں ڈاکٹر سلام بات کر رہا ہوں سر.
جی جی ہاں کر لیں.
ایک کوشچن لکھا ہوا آ رہا ہے کہ از آٹو ٹرانسفیوژن سیم ایٹ ڈیلیوری ایٹ ویجائنل اور سی سیکشن.
Yes, it's ultrasonic is just the same. It's so in section when in the vaginal delivery it's 500 mils, and the ultrasonic is the same. The uterus is contracting, so it would be the volume of the blood should be the same, but what happens is in the cesarean delivery the blood loss is a bit more, so the benefit is not that great as that happens in the vaginal delivery. You know what I mean? There's about 200 mils of blood loss more than it happens in vaginal delivery in a section. So that's why. But as far as the autotransference is concerned, it should be ideally the same if the uterus is well contracted.
جی ارسلان.
سر ایک اور کوشچن لکھا ہوا آ رہا ہے کہ کین وی یوز لو ڈوز اسپائنل فار سیویئر ایم ایس ود ریگارڈنگ کہ اگر کوئی پیشنٹ ایپیڈورل ریفیوز کر دیتا ہے تو کین وی گیو دیٹ.
So the first thing is, why are you calling it a severe MS? What's your rationale? I mean, if it is a severe MS as well as the classification, then you can't give spinal. You can't give spinal to them. And if you wanna give them, if you want to do it in a low dose spinal, the low dose spinal will not be sufficient to block all the dermatomes. Okay, so if you want to give it like 0.8 mils, the 0.8 mils is not gonna adequately block all the levels, so no. My answer to that would be no. If a severe MS patient and you're just giving low dose spinal, I think that's not gonna cut the clutter.
جی ارسلان ہے اور سوال.
بس سر لاسٹ یہ لکھا ہوا ہے واٹس مین ڈیفرینشیٹنگ اینستھیٹک کنسرن فار نان پریگننٹ لیڈی اینڈ پریگننٹ لیڈی ان والوولر ہارٹ ڈیزیز.
ہاں یہ تو سر نے شروع میں ہی جو ان کی فزیولوجیکل
تھوڑا ہاں شروع میں ہی ڈسکس ہو گیا تھا.
اس پہ تو ہم یہ پوری ویڈیو میں وہ یوٹیوب پہ ابھی اپلوڈ کر دیتا ہوں, وہ جو مس کر گئے ہیں وہ اس کو دوبارہ سن لیں گے. तो मेरे ख्याल क्लोज करते हैं, हम ओवर टाइम हो गए. डॉक्टर साहब,
जी
इट
सर.
वाज एक्सीलेंट. और ये हमारी जो क्लासरूम की जब से प्रैक्टिस चल रही है, इट्स हाई रेटेड क्लास. इसमें काफ़ी हमारी
एग्जैक्टली सर, 68 पार्टिसिपेंट्स
हाँ
रिकॉर्ड हुए हैं
व्यूअरशिप
फर्स्ट टाइम.
ना उसमें. हाँ जी, ये उससे पहले एक क्लास में हम 60 प्लस गए थे. तो आपकी फैन क्लब काफ़ी बड़ा है, काफ़ी लोगों ने आपका
No, I'm
नाम
honored for you, sir, I'm honored for you to invite me. It's
और
been an honor.
वी आर होपफुल कि इंशाल्लाह हम फ्यूचर में भी आपसे लेंगे इस पे लेक्चर. और
Good.
ऑप्स एंड गायनी में हमने डॉक्टर तनवीर से पहले कमिटमेंट ली हुई है, उनसे हम लेक्चर
Good.
लेंगे. तो डेफिनेटली आपसे भी उससे हेल्प लेंगे. तो थैंक यू सो मच. इसमें मैं अभी इसको अपलोड भी कर दूंगा, जो लोग नहीं इसको देख सके उसको दोबारा से देख सकें. एंड विद दिस
Very much.
थैंक यू सो मच एंड गुड बाय, गुड नाइट.
Thank you very much. Thank you very much, everybody. Thank you.